Hello, good afternoon, everybody. I'm Magdi Shenouda. I'm one of the GP reviewers with a team of Rowan Kenny and Craig Lawton. We are very pleased to be with everyone around today. And as a Manchester City fan, I'm very pleased that Jurgen Klopp is leaving Liverpool end of this season. What we're going to do today, I'm just going to give a quick introduction about pathways and guidelines. Rowan, excuse me, will talk about PSA and the erectile dysfunction. We hope that one of the urologists from Sheffield Teaching Institute, Mr. Christopher Hillary, is on his way. And then feel free, end of our presentation, to ask any questions, and we hope to answer them as appropriate as possible. So, as I said, I'm Magdi Shenouda. Guidelines and pathways, we all like them because they help us to decide what's the best thing to do to our patient. We work as a team nowadays, including GPs, PAs, advanced nurse practitioners. Guidelines and pathways are here for us to help us, to guide us what's the best thing to do. This is just a quick slide. I'm sure everybody is familiar with all the resources we have. We all know about the clinical knowledge summaries, which is produced by NICE. Not every particular topic you will find the pathway or the guidance, but it's worth looking when you see the patients in the office or in your surgery. We also want to highlight that, as Emma mentioned, that the press portal still exists, still named as Sheffield CCG portal. So please, if you get any reply or any recommendation from ourselves referring to the press portal, this is the link to their websites. We also recommend to look at the British Association of Urological Surgeons POSE. It's meant to be for secondary care, but there are still some very nice topics written for primary care. And definitely we have our press portal. As I said, they are mainly for primary care, but also we recommend to look at our website, Primary Care Sheffield. We added some top tips and we covered very briefly some of the common themes for the referrals, and I'll come back to that in a minute. We also recommend, that's one of Rowan's favorite, the Cambridge University Hospital, which has got some GP information. It's one of the resources you can look at to decide what's the best thing to do for our patients. One of the things I want to talk about today is the recently added pathways. They are produced by Sheffield Teaching Hospital Urology team with our input, and as I said, they are mainly written for primary care. They are really very good to help you, and you will see when I show you one of the documents that the format is almost the same. As a primary care clinician, we always like to rule out any red flags first. What's the urgent thing? Should I refer as 2 weeks referral? Should I organize any investigation? Because like Emma said, the whole point is to get the referral with all the information needed for the secondary care team to take the patient to the right clinic and to give them a chance to decide what's the best outcome or what's the best thing to do next. So these are the 3 recently added to the press portal, which covers recurrent UTI in females under 60. Remember that we do not review any pediatric referral letters, and of course the guidance or the pathway does not actually apply to men or to females above the age of 60. And there is evidence base for that, and I strongly recommend whenever you have time just to look at the press portal and look at these. We also added another one, which is the scrotal lumps. It does not cover everything, but the main ones or the common ones, which is hydrocele, varicocele, epididymal cyst, and the last one was the foreskin. Again, not covering every particular penile problem or whatever, but there are some useful information to help us as primary care team to decide. We are working on other pathways and guidance. My colleague Rowan is working on a summary of erectile dysfunction guidance and the renal masses, which includes what we call the AML or the angiomyolipomas. Hopefully it will be reviewed by STH urology team, and once it's ready, it will be added to the PROS portal. I'm working myself on a massive topic, which is the catheter problem. I know we work closely with the district nurses team, but we hope that we will get it ready before the end of this year. Let's be optimistic, okay? So what we have done, we got a list of the common themes for referral, and one of the reasons for that is to help us to put our priority, what needs to be addressed or highlighted in terms of pathways and guidance. And as you can see, most of our referrals included in this list: the lower urinary tract symptoms, persistent non-visible hematuria, recurrent UTI, scrotal lumps, and testicular pain, erectile dysfunction and ejaculation disorder, raised PSA, sterile pyuria, benile and foreskin problem, imaging query, and I just wanted to add a few words here. As we all do, we get the patient, we decide to do more tests, we send them for an ultrasound scan or CT scan, sometime for a urological problem, sometime for a different problem, which is not uncommon, and incidentally, they found a renal cyst or AML or whatever. Like Emma said, we do discuss these things with our mentor, Mrs. Beverly Wilkinson, and the other urologist team from secondary care team, and they do liaise with the radiologist to decide again whether they need referral or they need further tests or whatever. So bear with us if we sometime reply to you and say this case will be discussed in the joint meeting between the urologist and the radiologist to decide what's the next step. As I mentioned, the catheter problem is not uncommon one, especially in elderly people, people with disability, thinking about the suprapubic catheter or whatever. I'm doing my best to summarize all the most updated information, and once it's ready, as I said, it will be added to the press portal. And of course, others does include several sort of things. So basically, I'm going to very quickly give you a brief idea about the recently added pathways, and Rowan will talk about the PSA and the erectile dysfunction, and hopefully when Chris turns up, we will have some question, but if not, we will be more than happy to answer any question. So recurrent UTI, as I mentioned, they are meant to cover females under the age of 60. And the reason for that if we imagine that the patient end up seeing a urologist in STH, they decide what further investigations will be needed. And we were just talking, me, Rowan, and Craig, about a very nice paper just recently added from Primary Care Society for urologists about the yield for cystoscopy, for example, when it comes to recurrent UTIs in young females. Natalie, can you put the first document on, please, which is the UTI?
Can you hear me? Sorry, Dad. I've got it up on my screen, Maggie, but it's not showing on the main screen.
That's fine. Because I've only got a few minutes, thank God Chris is around now. So I'm just going to very briefly highlight what's written in the document. But as I said, please, when you get time, have a look on the press portal. What's the definition of recurrent UTI? ABC. We see letters with a female, 25 years old, typical scenario, has got 2 UTI, likely postcoital or whatever, and they need to be further detailed. So the definition is 2 or more in 6 months or 3 in 12 months. So please look at the patient record as we always do, and then you decide whether you would call that a recurrent UTI in a young females or not. The format of the guidance, when you look at the press portal, they always rule out any red flags. They give you the symptoms. They tell you whether to examine. Obviously, we all need to have a proper examination, including gynecological examination for females or genital examination for males. You need to ask ourselves whether it's an upper or lower UTI, and we are all familiar what are the symptoms of the upper urinary tract infection, because that's take us to a slightly different area in terms of how urgent they need to be seen or whatever. Please, simple tests need to be done and ideally included in the referral letter, the urine culture and sensitivity, because it does make a difference sometimes when it comes to the organism when it appeared on the culture. We have our local guidance from the microbiology team at Sheffield STH. Also, you need to do routine bloods in terms of blood count to see if there's any infection, any leukocytosis, blood sugar, things like that. Ideally, if you can arrange an ultrasound scan, including the post-void residual, and that's again another idea. I think Chris can give us more information about it. Forgive me, when we get excited, when we see a residual volume of 120 mL or whatever, but roughly speaking 200 mL or more, that's when we decided to take it further. And of course, after all the tests, if everything is okay, we might consider prophylactic antibiotic, and the documents, when you you can see that they recommend either nitrofurantoin or trimethoprim. It might be single dose, say if you know the trigger, like postcoital 100 milligram of nitrofurantoin postcoital, or the maintenance prophylaxis. Again, the details are included on all in the document. One of the other options is non-antibiotic, like the Heprex, which is available, the Demonose. Some people use cranberry juice or whatever. Please have a read of all these documents. Quickly to talk about scrotal lumps. As I said, it does not cover everything, but please try. We all do our best to rule out any red flags. That's our first priority. Say, for example, if somebody suddenly got a hydrocele and he's a male between 20 and 34, that's the age when you do expect them to develop testicular cancer. Same when you get sudden varicocele, especially on the left side. Think about any retroperitoneal or abdominal or renal tumors. And if you examine the patient, the male patient, and you cannot distinguish the testes from the varicocele, then it would be appropriate to take it urgently. We definitely recommend to have a routine ultrasound scan, obviously unless there is something urgent, because ultrasound, we have the choice either to put it as urgent or routine. One of the options we recommend, if the patient is asymptomatic or the symptoms are simply controlled with analgesia, including whatever you like, is to advise them to have scrotal support. One of the common questions people with varicocele, especially young males, whether it affects their fertility or not. The answer, most likely not, but I'm sure Chris can clarify more about this particular point. For skin, we always say we do not recommend referral for, say, consideration of circumcision on a religious point or just purely cosmetic. But if it does affect them mentally or the function, what I mean by function, they urinate and they have spraying and ballooning or whatever, or in other words, if they are sexually active and they get pain and cracks and recurrent infection, we all recommend that you consider the referral. There are definitely, as usual, any red flags need to be ruled out in terms of urinary retention or any skin manifestations. The most scary one, which I've seen it twice in my career, which is called Fournier's gangrene. If there is any skin cancer or STI, you need to work it out before you decide the referral. We all familiar that there is a referral form for consideration of circumcision, and I'm sure you're all familiar that there is what we call individual funding request. It's a long process, but we do need the filled form if you think the patient needs circumcision. Non-visible hematuria, not uncommon. Again, very quickly, just to tell you, what's the definition of persistent non-visible hematuria? We need to repeat the dipstick at least 3 times and at least 3 weeks apart, not just one incidentally done with work checkup or whatever to find RBCs. Not to mention that you do need to look at the MSU or the microscopy of the urine, because sometimes you get a positive blood in your dipstick, but there is no RBCs in the urine microscopy. So again, I'm not going to talk about why that doesn't happen, but we'll be more than happy to, if you want to talk about in more details. Of course, there are some transient reason for microscopic hematuria, which is commonly UTI, whether in males or females, especially in females. If they have any bleeding, vaginal or menstrual disorders or irregular period or whatever, please always check the blood pressure and the urinary protein creatinine ratio, because typical scenario, a middle-aged female accidentally come for a reason or another and you dipstick and there is some blood in the urine dipstick. It could be a nephrological problem rather than urological problem. So we would like you to check the blood pressure more than once, to check the PCR, then you decide whether it's a urology or nephrology case. As a general rule, we all respect patient choice, but if you talk to your patient, I'm going to refer you for varicocele or circumcision, and the patient say, no, I don't like any surgical intervention, then ideally you include that in your letter, or you tell the patient to think about it. Of course, secondary care will do the same once they decide what are the options for the patient, and they respect the patient choice. If the patient is not surgically fit for any operation, again, I would personally think about other options before I decide to refer them. Typical example, if somebody is diabetic, whether type 1 or type 2, and is poorly controlled diabetes with HbA1c above 70, they will not do anything unless we get the diabetes controlled. I'm afraid I'm going to stop here, so I will pass the mic now to Rowan. And as I said, please feel free to ask us as many questions as you want. Thank you.
Thank you. So 2 quick sort of urology subjects which are part of our day-to-day business. One, PSA testing, and the other one, a quick update on lower urinary tract symptoms and the connections with ED and with cardiovascular disease. So it's stuff that you'll all be sort of familiar with, but hopefully I'll add a bit of value today. Why are we doing PSA? It's the most common cancer for men and the second most common cause of cancer deaths. The plan to sort of revolutionise PSA testing was announced in 2019, but we've been quite busy since then with other distractions. The PSA should be offered to all men over 50, over 45 if they have a family history or if they're black, Afro-Caribbean, on request, okay? We should not be persuading men not to have a PSA. I'll come on to why in a minute. New research from Prostate Cancer UK supports possible introduction of screening, but let's not hold our breath for a national programme. And just a quick reminder that trans women usually still have prostates, so don't forget to offer PSA screening to post-surgery trans women. Why is it a priority? Why do we need to do more PSA testing in younger men more often? It's because about 40% of all prostate cancers are diagnosed in stage 3 and 4, about 20% in stage 4. These figures are only up to 2018. They may have changed since then, I'm not sure. And you can see by the graph on the left that 2-week wait referrals for prostate cancer dropped off a cliff around the time of the pandemic. So people didn't stop developing prostate cancer, but less were referred. So it may well be that there's a kind of tsunami of late diagnosed prostate cancers coming. Risk factors, I'm sure you'll be aware of, just whiz through. Median age is 67. It's rare under 50, but not impossible, and very common over 80. Double the risk for black men. It's a slightly lower risk in Asian men. It's double the risk, more than double the risk if you've got one first-degree relative with prostate cancer. Quadruple the risk if you've got 2 or more first-degree relatives. And also there's an association with the BRCA2, possibly 1 genes. So do we do PSA for men with LUTs in case they have prostate cancer? Well, the guidelines suggest that we do. I don't know why they've done this in a funny order. So sorry about that. So NICE guidelines say offer a PSA and a DRE to men with LUTs to detect prostate cancer. But there's not a great deal of evidence to say that you're more likely to have prostate cancer if you have LUTs. So basically, the guidelines should read, for us in primary care, it should read, any man who wants a PSA, really we should be offering them, whether they've got LUTs or not. Remember that LUTs are really common, okay? So 80% of men over 60 have LUTs that they might present. So remember, the majority of men presenting with early prostate cancer have no new or additional symptoms. They may have LUTs, but they probably had them for other reasons. So if you're as old as me, you might remember that years ago, people used to make fun of the American system, private healthcare, testing PSA when it's not necessary. Evidence shows that all that PSA screening that was done in the US years back, and you can look this up if you want, was worthwhile, and prostate cancer mortality reduced by 42% during what's called the PSA era. And about 40 to 70% of that was attributable to PSA screening. Does that translate to Europeans? Yes, it does. 2007 Swedish study showed that if your PSA was under 0.5 at between 44 and 50, you had a very low risk of going on to develop prostate cancer later in life. But if your PSA was between 2 and 3 at 45 to 50, your odds of developing prostate cancer were 19 times higher. Like I say, European studies have backed up that prostate cancer. What happens if you do a PSA and you refer a man up to the urology department? If you've not had an update recently, you might think it's still the old medieval, you know, probe up the backside and 12 biopsies, but it's not. The multiparametric MRI has transformed early prostate cancer diagnosis, and the biopsies often now are MRI guided transperineal, so it reduces the risk of sepsis by doing transrectal. So if you want to look this up in more detail, the Precision and Promise studies show that if the multiparametric MRI is not suggestive of prostate cancer, it may save about a quarter of men from having an unnecessary biopsy. So this is a step change. Some of you will be familiar with this, some of you might not be. So Prostate Cancer UK have done fairly recent research based in 16 NHS hospitals in the southeast, and screening has been shown to reduce prostate cancer deaths by 20%. Now the caveat to that historically has always been, yeah, but what about all the anxiety and the unnecessary, the sepsis from the unnecessary biopsies and the morbidity from the unnecessary biopsies? But actually the introduction of scans now means that far fewer biopsies are done, and the ones that are done are for those men where the relative risk is less because they are more likely to have prostate cancer. So during this trial, 67% fewer men experienced harm and 64% decrease in the number of unnecessary biopsies. So if this is new to you, just remember, if you're advising men about having a PSA, we shouldn't be saying to them, oh no, don't have a PSA. You never know. You might end up with an unnecessary biopsy and a cancer that never needed treatment. We should be offering a PSA to all men who are interested. We should also be considering offering a PSA to all men between 45 and 50 as a baseline. The European Association of Urologists recommended this as far back as 2013, and it's certainly something I offer to my patients. Okay, that's PSA in a rapid nutshell. If you want to discuss it more, I'm more than happy to afterwards. Second thing is just a quick reminder about erectile dysfunction, cardiovascular disease, and lower urinary tract symptoms in primary care. You probably know that erectile dysfunction and cardiovascular disease are often linked. You might not know that LUT is often linked with erectile dysfunction and therefore with cardiovascular disease. So if you want to switch off for 4 minutes and have a nap, the shortcut to this is if you see a man with either ED or CVD or LUT, consider the very likely possibility that they've got the other two as well, because they may need addressing. So anyone with ED needs a cardiovascular risk assessment, at least do a Q risk and take it from there. And we'll talk very quickly about treatment. I won't go into this in detail because we're a bit short on time, but basically in this trial, there's plenty of evidence to say that ED happens in men about 5 years before their first coronary event. So think if you've got, especially a younger man in their late 40s, 50s, presenting with ED, about 70% of ED has a vascular origin or is at least partly vascular, and therefore think of that as a warning, and you get in there with your statins and your lifestyle modifications, and that will make a difference. Ignore the rest of this apart from the top line, and this is a study which shows the number of coronary artery disease events per 1,000 patient years. And in this age group at the top, the 40 to 49-year-olds, you can see that the number of cardiovascular coronary artery disease events is much higher in that age group over time compared to men with no ED. So the younger the man with ED, the more concerned you should be about their ongoing cardiovascular risk. How often do LUTS and ED coexist? If you look at so in primary care, the second graph there, it's between 32 and 60%. By the time they get to urology clinic, it's more like 70, 75%. So if you're doing a referral, which is what this session's all about, think very carefully about if you've got a man with LUTS, have you asked him about ED? And if you've got a man with ED, have you asked him about his LUTS? So if cardiovascular disease and LUTS are linked, then, if cardiovascular and ED are linked, and ED and LUTS are linked, then it makes sense, doesn't it, that if you can moderate the risk factors for cardiovascular disease, you can help the ED. You can also help their lower urinary tract symptoms. And that, at the moment, is not, I think, common practice. This study shows that if your BMI is over 30 compared to under 25, your odds ratio for developing LUTS is 1.41 to 1. So it's significantly higher. And it also shows that high activity will reduce your risk of LUTS, and even just daily walking. So there's lots of lifestyle advice you can be giving to these men with LUTS for their LUTS, but knowing that it will help them with their cardiovascular risk as well. So overweight and obese men have a higher risk of LUTS. And physical activity reduces the risk of LUTS, as well as reducing their cardiovascular risk, improving their erectile function. Just a very quick bit of data. So these were two studies. You could perhaps look at this in more detail. But basically, it's about the benefits of using PD5 inhibitors. You get a reduced all-cause mortality in diabetics, and in men, you get reduced risk of cardiovascular events. So if you're worried about prescribing PD5 inhibitors, don't. The outcomes generally are very good. And this might be one thing, if you take one thing away from the urology talk today, maybe this, and that is that PD5 inhibitors treat LUTS. We shouldn't be surprised now that we've associated LUTS, ED, and cardiovascular disease, but there's very high-grade evidence to say that using daily tadalafil helps men with lower urinary tract symptoms. And this is not, I think, commonly practiced. If you look in the BNF, you'll see that it's licensed for BPH. I think it might still be blacklisted or amber listed, I'm not sure, but it's not expensive. So in that group of men, and I'm sure you've all got them, they're in their 50s or 60s, they've got LUTS, they come to you, you give them tamsulosin or you give them finasteride, and the ED that they've already got but that they didn't tell you about, but we've ascertained that they are likely to have, gets worse. They stop taking the tablets. So there is a small group of men where using a daily PD5 inhibitor can help both the LUTS and their ED. So quick summary for ED and then I'm done. Give an adequate number of PD5 inhibitors. If a man comes to you with new erectile dysfunction, he's probably had problems for months or years. I give mine at least 6 weeks worth, and I give them 3 tablets to take a week, whether it's sildenafil or tadalafil or whatever. Tell them that it'll get better over time the more doses they use. I tell them to use it by themselves as well, so they don't feel the anxiety, the stress to go with it. If one doesn't work, try another, because there is evidence like triptans that maybe one will work if another doesn't. Encourage the other parts of sex that a lot of men bypass, and work on comorbidities, because the comorbidities of ED are the same as coronary artery disease and LUTS. Think about hypogonadism, and if you need to refer, because we've got a great urology department for dealing with those. The end. Sorry about the rush nature, hopefully some questions at the end. I'm going to pass you over to Chris Hillary. I'm not sure if David's coming up on the stage or not. Thing to do now. Do you want to?
Yeah. Well, I kind of thought, because both you and Magdi have covered quite a lot of the topics in your talk, so I think I might just whiz through some of these and see if anybody has any questions specific to what.
With the microphone.
Yeah, perfect. All right. Thanks, Rowan. Hi, everyone. My name's Chris. I'm here with my colleague Dave today. We covered quite a lot of that, and actually Magdi's managed to cover quite a lot of our talks, and Rowan as well, certainly in response to PSA testing. Dave and I are urology consultants at the Hallamshire. We both spend a significant portion of our time mainly doing cancer, but also doing male and female urinary symptoms, erectile dysfunction, investigation into hematuria, raised PSA, etc. And by and large, this is the vast majority of the different things that we see. But in red is probably makes up 90% of the cases that are actually referred through. So they're all pretty common. Magdi did speak about catheters, and I agree a lot of patients that you see might have indwelling catheters that drain poorly, they block, they cause urinary tract infections. I'm a big advocate, as I'm sure that Dave is, about suprapubic catheters draining better. They do drain better, they're easier to change, they're associated with fewer urinary tract infections, but actually they are difficult to put in. They're often not straightforward to put in. They often require an anaesthetic to put in and not just ultrasound, and they don't always fix people's problems. They are available. We are happy to see people and refer them through. There are different catheters that you might see. Probably the district nursing team might see a little bit more. Magdi covered some of these kind of inguinoscrotal conditions. Down at the bottom left you see varicoceles, and I agree. And I just pick up a few points that he did make in his talk. One of them was fertility rates and varicoceles. There's no good evidence that would suggest that repairing somebody's varicocele will improve the take-home baby rate. Fertility parameters might improve, but if somebody is coming through to you concerned that they're not going to be able to get pregnant because they have a varicocele, it's entirely false actually. The semen parameters might get better, but it won't end up with them successfully taking more babies home at the end of the day. We do repair varicoceles. I'd repair a varicocele if it's painful. It isn't straightforward, and I'd certainly be looking if somebody has a really high-grade varicocele, if it's visible when somebody stood up or lying down rather than on a Valsalva manoeuvre or a subclinical varicocele on an ultrasound scan alone. They're more common on the left because the left gonadal drains via the left renal vein before it goes into the IVC. The ultrasound department are actually quite good. If they see a varicocele, they'll automatically scan somebody's abdomen, so you don't get them being referred back to recommend a scan of their abdomen just to make sure they don't have a renal tumour. I was going to talk about a couple of things, but I did just wonder, did anyone want to ask a few questions about any kind of andrology problems that are listed on there aside from varicocele? When to refer people, or what kind of preliminary investigations to book? So I can just move on and we can answer some questions at the end. Got some pictures, incidental findings, groin problems, hydroceles, balanitis serotica obliterans, phimoses. By and large, if things are giving people a problem, then we'd look to see them and repair them. They're all pretty common. They're rarely associated with life-threatening conditions. I think a new or recent onset hydrocele is described in textbooks as being associated with testicular cancer, but I personally never seen it. I don't know whether Dave's ever seen a new hydrocele being caused by a new testicular tumour. Epididymal cysts, you know, we can repair them, but somebody has to have a lot of pain to do it. We do see people, around about 10% of patients, having an epididymal cyst repair, a hydrocele repair, who end up with chronic pain actually worse than the original problem. Infections, a few things on infections, and again, Magdi did mention recurrent urinary tract infections, completely agree. There is a paper, it came out of Newcastle, and it compared prophylaxis and how long for antibiotic prophylaxis, generally between 3 and 6 months, NICE would recommend, and then stopping them to see what happens. Hiprex is also a good option. I'm not sure whether it's available in primary care. If it is, that's absolutely fantastic, actually. It's methenamine hipurate, I think it is. You won't know. We see a lot of prostatitis. It's rarely acute infective prostatitis. It's very, very rarely chronic infective prostatitis. It's usually an acute inflammatory problem. And we tend not to do things like prostatic massage anymore because it's vulgar. And a lot of other incidental findings that we see, and Dave's going to talk about some cysts, angiomyolipomas that we see. You might see hydronephrosis, how to manage patients with hydronephrosis. Top, we've got testicular microlithiasis, pretty common. If it's present unilaterally, somebody has 2 testes in absence of a history of testicular cancer, self-examination is all that they need. If somebody has really quite profound coarse calcifications, like in this case, or they have a solitary testis, or there's a concern that exists about them having testicular cancer, then they can either be referred or repeat an ultrasound in a year's time. It's absolutely fine, but it is pretty common. It's very rarely associated with underlying testicular cancer. So horseshoe kidney, sometimes it risks patients having stones or kidney tumours, poor drainage with hydronephrosis, but if somebody is completely asymptomatic, they need no treatment. That's a duplex kidney on the far side, much the same as horseshoe kidney. It is present, it is pretty common, 100 to 200 people, and it tends not to cause much in the way of symptoms, except for younger patients where they're at risk of reflux and urinary tract infections. I think there's some renal cysts, and again, Dave's going to talk about them, and the vast majority of kidney cancers that we see are incidentally detected. Probably a third are incidentally detected, actually, so it's pretty common to find them on scans for other things. Hydronephrosis, if you do an ultrasound scan, you find an incidental hydronephrosis, absolutely fine. The question is, what's causing it? Is it a pelvic-ureteric junction obstruction? Is it painful? Is it a ureteric stone? Is there actually a tumour, whether that's in the ureter, whether it's in the bladder? Is the ureter being compressed by something else? Do they have a coexisting cancer that's causing retroperitoneal fibrosis? There's loads of different causes. Generally speaking, a CT scan will answer a lot of those different questions. Whether we do that, whether you guys in primary care do that, it's absolutely fine, and let us know if you need our help. I'm not going to talk about renal failure. The IPSS questionnaire, I mean, patients at the Hallamshire, it is in a bit of a state at the minute. We're not getting people through for surgery. We're not therefore getting patients through for their follow-ups or their new appointments. And it's not unusual for people referred through with a hydrocele or urinary symptoms to be seen, you know, waiting 9 months perhaps, waiting 12 months for their appointments. So it would be fantastic if a lot of these guys could be managed as much as possible in the primary care setting, which I suspect is the goal of why we're all here today. It's an IPSS questionnaire at the top. Severe symptoms would probably be in excess of 18 out of 35. Quality of life score at the bottom. That's a frequency volume chart. We use that really. I don't give it to all patients, and duration of how long people use it for is kind of a bit moot actually, but I'd use it to see if somebody's complaining about nocturia, do they have nocturnal polyuria? And if they are avoiding a lot by day, actually do they have polydipsia, do they have global polyuria? So nocturnal polyuria is an increased proportion of the urinary output produced at night or during sleep. And actually you ask them to cut down the caffeine, reduce their alcohol, and correct any cardiovascular complications, and they generally speaking get better. I use desmopressin a lot actually. I'm not sure what you guys think about that. And we could probably just skip this as well. I think Magdi spoke about it. And then I was going to get Dave, and Dave will talk about some of the incidental findings you might see on the scan before we kind of answer some questions that you might have or you might not have.
Yeah, cool. Afternoon, everyone. Rowan, how long have I got? 10 minutes. Perfect. 2 things to start. Wish the world my Sheffield United top. That's the first thing. If King Charles has prostate cancer, then I guarantee that PSA screening will be in force in the UK within 5 years. But he's probably got bladder cancer, but we'll wait to find out. I'm going to skip to one of the slides. Myself and Bev Wilkinson do the NHS e-referral triage thing. So I'd like a show of hands, because we reply to quite a lot of you guys with ultrasound reports saying, can you book a CT scan? So just for my kind of information, with a show of hands, who's able in primary care to book a contrast CT scan if we ask you to do that? You all are. I've had quite a few snotty replies from people saying they're not able to do it over the last few months. So is that true or is that not true?
I can't imagine the No, it's from, when we write back saying, can you please book a CT scan because there's a 1.5 centimetre AML and an ultrasound scan, I've had some GPs replying saying we're not allowed to do that. So we don't know in secondary care what the rule is in terms of who's allowed to book scans.
You can speed it up. You can get an earlier appointment rather than comes from us.
Right, okay. That wasn't what I was asking.
I think there's some confusion, to be honest, because there was a time that we could do MRIs, which were then taken away from us.
Right, okay.
Maybe some of our colleagues are kind of thinking, well, all kind of scans, I don't know. But
Yeah, okay.
So I had a patient I referred and I got that response back, and I did book the CT, but it really wasn't clear who would follow up that result and who the responsibility lay with. So some clarity on whether or not they're actually waiting for an appointment beyond that would be helpful.
Yeah, that's a good point. So maybe when we reply to you guys saying, can you book a CT, we can write in our reply how that follow-up will do. But just coming on to then two things. So if you have an ultrasound scan that shows a renal cyst and the radiologists give you a classification, so this is the classification for Bosniak, you can ignore 1 and 2 completely. So if you get a report back saying it's Bosniak 1 or 2, you don't have to do a CT scan or refer the patient. If you have anything other than that, then they need a CT scan. So we might write back to you and say, can you book a contrast CT scan? But I agree that you guys need to know what to do with that result. So we can work on that on our side in secondary care. The other finding commonly on a scan that you might get is, it's not that, it's that. So it's an angiomyolipoma, which are really common. So the radiology guidelines say if it is less than a centimetre, less than 10 millimetres, you don't need to do any more scans. But if it's over a centimetre, you need to do a CT scan. And again, that will come back to, can you guys do that? But we need to give you more guidance. You only ever really intervene if an AML is over 4 centimetres. And the risk is a lot higher if you're of childbearing age because of the hormone influence on AMLs. So we don't do very much with AMLs unless they're massive or it's a lady who's of childbearing age. But we would see the patient to have that conversation if the AML proven on a CT scan is more than 1 centimetre. So we need to send you guys some guidelines about how you interpret the AML report and when we'll see the patient, basically. Yeah, and that's basically, I think, all I had to say, really. But me and Chris are happy to answer any question.
Thanks, David. Thanks, Chris. So, any questions, either on what's come up or any other common urology queries? I know I've got one while you're having a thought, and that's about sterile pyuria. I know there's a lot of things we can do in primary care to rule out the kind of false positive sterile pyurias where people have got vulval or vaginal issues. But if we feel we've covered all that, we're kind of getting slightly mixed messages about whether people still need to be referred. I've come across, not a patient I've seen, but I've come across people being told, no, this patient doesn't need to come to urology from urology, and others saying, yeah, send them in. Any comments?
I'll start and Chris can finish. I've never seen a patient in my whole career who's got tuberculosis because of sterile pyuria. So it's in the textbooks, but it doesn't exist as a thing.
Is it associated with bladder cancers at all in the absence of non-visible hematuria?
No.
There we go. So what would be really helpful for a lot of people, I think, would be if there was some written guideline about sterile pyuria. It sounds like it only needs to be very short. Because that is one of the things. It's not one of the commonest, but it's one of the ones that we kind of and ah a bit about. And I think there's probably different levels of concern in primary care.
I'll probably expand on it and what I'd be happy to see. I think Dave's really kind of resenting being at Hillsborough, to be completely honest. I think he's going to set on fire if he stays here for too much longer. So the patients that I'd probably see and I'd investigate with sterile pyuria, certainly those who are heavy smokers, males over the age of 65. I'd have a little bit more, I'd be a little bit more cautious with them. If somebody is symptomatic, they have bladder pain or they have urinary tract symptoms, you know, urinary urgency or urgency incontinence, what you can do is you can do an ultrasound scan, and that'll exclude the presence of upper ureteric stones or any renal problems, hydronephrosis. It will show you whether there is an obvious bladder tumour. They'd also do you a post-voiding residual at the same time, if it's written on the request. So that'll exclude the presence of a lot of severe problems. I'd probably investigate patients who've had visible hematuria as well. In total, I'd expect that if somebody came through our system with sterile pyuria that's unexplained, and they obviously don't have TB, or schistosomiasis actually as well, I would offer them an ultrasound scan, a post-voiding residual, urine microscopy, some early morning urines for TB or a quantiferon if they're at a high risk, and a flexible cystoscopy. I probably wouldn't do anything too much else. If all of those tests came back negative, I might be half inclined to give them a prophylactic course of antibiotics for 3 or 6 months, retest a microscopy afterwards, and treat their symptoms. Is that helpful?
That's great. That's great, thank you.
Perfect, all right.
Any other questions?
Just out of interest, circumcisions are not allowed on the NHS. Now, very early on in my career, they were done sometimes in not the best of places, and we used to see quite a lot of problems. Now, circumcisions within certain communities are still done for religious reasons. I just wondered whether you see, because I haven't seen any problems for years now, whereas I used to get the odd one that was kind of done in a GP surgery somewhere near Manchester or whatever. I just wondered whether you still see any problems.
I mean, routine circumcision or cosmetic circumcision is, as you quite rightly say, is no longer available via secondary care. There are kinds of ways and means around that, not necessarily to try and sneak patients through, but we do a lot of circumcisions, whether that's on an NHS basis in Sheffield teaching hospitals, whether it's on an NHS basis through one of the private hospitals. We do a lot of circumcisions, and it mainly is for patients who have a pathological phimosis. There are 2 types of phimosis. There's a physiological one that all children have up until the age of 16 would be around about 1% of patients will remain to have a physiological phimosis by the age of 16. But some can remain with it. A pathological phimosis is one that's generally caused by balanitis serotica obliterans. It's a scarring condition. It rarely settles with topical steroids. And a circumcision, it may be somebody's only option. Generally speaking, though, if somebody's phimosis is interfering with hygiene, intercourse, it's causing pain, spraying when somebody voids, we'll treat them. It's not too much of a problem at all, but I think what you're referring to is a routine circumcision, one for either cosmetic or religious reasons, and unfortunately, no, the answer is that's not available anymore, really, but I do take your point about them being performed badly.
No, so my question was, are you actually seeing any problems that are being referred to?
I've seen a couple while I've been on call of really we don't take a paediatric population anymore at the Hallamshire. That tends to go to the Children's Hospital. So I saw a few cases when I was a registrar of awful complications after a circumcision, kind of religious circumcision, really. Don't know whether you've been at the Hallamshire a lot longer, so you won't see anything now.
Maybe squeeze one more question in.
Thanks. It's about the fact that we're almost revisiting the way that we look at PSA investigations, and gone are the days where we'd say PSAs need to trust biopsies and all the things about that there are now methods of multiparametric MRIs. And I suppose my question was, in the old advice that we used to have about PSAs was that there was a false negative and a false positive rate for that. Has any of that still changed? And secondly, what do we do with the patients who, in our population, with a slightly kind of more informed in some respects, and they come to us often asking my PSA is normal, can I have a multiparametric MRI from you, doctor? I've had these requests from us. I've always told them no, but is my approach correct? How should we approach this, particularly if more men present with normal PSAs with no other reason to do anything, but still come asking you for MRIs?
Okay, so good question. I think we've gone back to the age-specific PSA thresholds, which we had a few years ago, which I think does make it easier for you guys in terms of who to refer. If a man has no family history, has a normal DRE, and he has a PSA level under the age threshold, he gets reassured and he doesn't get referred or an MRI scan. But if you can have a normal PSA with prostate cancer, but they always have an abnormal DRE, and they always usually have a family history. I think the problem we have with PSA is when we do our MRI scan and negative biopsy, it's how we help you guys follow them up and know when to send them back. So we don't give you guys enough steerage in terms of what PSA thresholds to stimulate a re-referral, and that's because we as a urology community don't know the answer. So we change our minds all the time about when patients should be sent back. There's a thing called PSA density, which is coming into urology practice, which is the relationship between the size of your prostate and your PSA level. And if you remember a figure of 0.15, then we potentially might be writing some guidelines where we say you can carry on monitoring their PSA. You'll only have one MRI volume to base it on, but if their PSA density gets over 0.15, then we will see them back, reassess them, and maybe do an MRI scan, a second MRI scan, potentially. But that guidance has not come out yet, but PSA density is going to replace all these things we've done over the years because we've changed the guidelines so many times.
Just for example, if somebody has a 100 gram prostate and their PSA is 10, that would be the equivalent of 0.1 to 10%. So, and it basically changes depending on risk. So you can have a limit of 0.1 or 10%, 15%, 20%. Generally speaking, yeah, 15% we'd want to see somebody again.
How happy would you be with a GP estimating volume?
Depends on how you estimate it.
Presumably your prostate grows over time, that volume is going to change.
Absolutely, yeah. The prostate probably will grow over time, and all you'll have is one MRI scan or one truss estimated volume at one point in a given time. And we just, if somebody's PSA exceeds or goes up, then we just have to see them back and reassess things, really, and reassess their MRI scan. If somebody's on finasteride, then obviously you take that into context when measuring the PSA, but it will also reduce down the volume of the prostate as well. A PSA will go up proportionately speaking to the volume of somebody's prostate, but it will go up disproportionately so with prostate cancer.
That's great. Thank you very much. We've overrun. So thank you all. Thanks for the questions, and we really appreciate your time breaking away from STH to come and help us out. And any ideas for guidelines, please communicate them through Emma or me or Magdi or Craig, and we'll liaise with the urologists and hopefully streamline referrals for the benefit of everyone, primarily the patients, but also for us as clinicians as well. Thank you. So up next is Tom.